What's up, guys? Today is Saturday, September 27. It's my one day off in this week of working. And so, they say that when you work long enough, you kind of forget how to live. And that's pretty much how I felt this morning. So, it's 4:40 p.m. right now. I went to sleep like exhausted at like 9 p.m. yesterday, and woke up at like 2 p.m. So I don't know how long that is, but I slept a lot because I was averaging like 5 hours of sleep for the whole week before. And if you guys have ever heard the song Sunday Morning Coming Down by Chris Christopherson or Johnny Cash, that's pretty much how I felt. So I had an appointment with Toyota in the afternoon at 3. So I kind of dragged myself out of the house and kind of drove through the city and, watched life go by, and, I was like, it would be nice to like, actually be living like some of these people instead of just getting a, one day off of work. But, anyways, one of my colleagues at work, his wife made some really good food. İçli köfte. I'll show you guys. It's this. It's a Turkish food. İçli köfte, and basically it's like it's a shell that's like fried, and then on the inside it looks like this. I mean, it's absolutely delicious. And so, one sec, I'm gonna swallow this. And so, anyways, this really changed my mood. It's really good Turkish food. I was honestly craving Turkish food today. And, anyways, there's a video I wanted to make for a while now, which is kind of reflecting on residency at this point, which is, I started residency June 16 of this year, so now it's September 27, so 3 months. I'm 3 months into residency now. And I'll talk about that. And then something else, instead of just going back home and, being, like just having nothing to do, I decided to maybe kind of explore the area a little bit more. So I'm at one of my favorite like small hikes here in the area. It's the Four Dances recreational area. And there's not much to see from here. This is just a parking lot. You can see the start of the trail over there. But once I'm done eating this good food, I'll show you guys the end of the trail. It's really, really beautiful up there. But anyways, how's residency going? So I'll primarily talk about wards in this video, like the inpatient service, because I don't know. I have a 3 weeks of clinic coming up in about 2 weeks, so I think I'll have a lot more to say about clinic at that point. But first of all, what I really like about my residency is that it's a 3+3 schedule. And the good thing about a 3+3 schedule is that you do 3 weeks of one like rotation and then you move on to another rotation. Now I'm getting to like the hard part of residency where, I'm going to have a bunch of wards rotations, and in between those wards rotations, I'm going to have some hard rotations as well, like ICU and nights and whatnot. But still, regardless, the good thing about a 3-week schedule is if you really hate something, you can still do it for 3 weeks. And I'm not saying that I hate wards, but it's when the schedule gets really, really tough, you just have to get past that 3 weeks. And I like that about wards. And like, anyways, if if you've been like listening or watching some of my other videos, you might have noticed that I talk about this the 3+3 schedule a lot, but the reason I really like it is because, and I for whatever reason I find a reason to mention it in every video, is because most internal medicine residencies are not like this. So I think I'm really lucky to have a schedule like this one. Because, like, for example, when I was on the interview trail, when I was back in medical school applying to different internal medicine residencies, I interviewed at like Creighton in Omaha, and at Creighton University the schedule is 12+1, and basically what that means is you work 12 days straight and get 1 day off, and there's no separate blocks for clinic and inpatient. Over there they have what's called a combined schedule, which is how internal medicine residency schedules were kind of a long time ago. So in other words, the residents there, they'll round in the morning, and then they'll go to their clinic, and then they'll go back to the wards after their clinic. And so it's just insane. And that's like, so once a week they have clinic over there, and then the other days are inpatient, right? But that's just insane, doing both clinic and wards on the same day. It's a lot of patients, a lot of work. So I'm really glad I didn't end up somewhere like that. Or, for example, another place I interviewed at on my residency, application and stuff was Lakeland, Florida. And the thing about Lakeland, Florida, is that I got like basically used car salesman vibes from there. Like, they were telling me like their schedule is 6+1, which means you work 6 weeks inpatient and 1 week outpatient. And the hours on inpatient wards, which I'll get into in a bit, are absolutely terrible. So working, 6 weeks on inpatient, like, I'm not even joking, I would have thoughts of like self-harm. Like, I mean, I'm joking, but like, that's absolutely terrible, right? Like, because yes, a lot of people prefer inpatient medicine to outpatient medicine, and I have my own like conflicting thoughts about which I prefer, but the schedule of inpatient medicine is way more demanding than outpatient medicine. So doing 6 weeks straight of it is crazy. But Florida was selling itself, Lakeland, Florida was selling itself like it's some amazing program, and they were also saying stuff like, "You'll never get admissions past 7 p.m." and stuff like that, or they were talking about how their doctor's lounge has food. Like, it's so compared to some of these other shady residencies, I really ended up at a good place. But that doesn't change the fact that residency is pretty hard. So how is wards going? How is residency going? So I'll start by talking about like my typical hours on wards, and then I'll talk about kind of the bad things and the good things about it. So typical hours on inpatient wards. I wake up at 4:30 a.m. I go through my morning routine, wash myself, pray, maybe stretch a little bit, do like 15 push-ups, get out the door. That takes like 20 minutes, and then get to the hospital by like 5:10, and then print the list. And so for the past like week or so, we got it fixed recently, but for the past week or so, the printer in our workroom wasn't working, so I had to like go find some other place to print my list of patients. So I print the list of patients, and I staple them and prepare that. That takes about 10 to 20 minutes. Strawberries and cream frappuccino, highly recommend it. But anyways, that takes like 10 to 20 minutes, and then after that I do what's called pre-charting. So for all of my patients, and the last couple weeks I've been really busy. I've had up to 6-7 patients, but the last few days have been better because we got a medical student with us, so now he's carrying some patients. But regardless, I've had up to like 6-7 patients. So for each one, you do chart review, right? So you look into their chart and you see what are their labs for this morning, what are their vital signs for this morning, what was their input and output for this morning, and then you look at the notes on the chart. Have there been any new notes dropped? Like, for example, if the patient is awaiting placement or rehab or whatever, you want to make sure you look at the care management notes, or the physical therapy notes, or if the patient is being seen by a bunch of other doctors. If you're sharing the patient, with surgery and surgery and palliative care or whatever, you want to make sure you read their notes too, because sometimes they drop things in their notes which they don't tell you about. Or like, for example, if you have a stroke patient and neurology is like driving the ship, you 100% want to make sure you note down everything they say, right? So you do that. If the patient has diabetes, you want to make sure you look at the core diabetes flow sheet, which is a tool on the electronic medical record we use, Cerner, to see how their glucoses were in the morning and after breakfast, before breakfast, after lunch, before lunch, so on and so forth. And then because, if you need to make some changes to their long-acting or short-acting insulin, you need to have that information. So you do that for every patient. If the patient has alcohol withdrawal, you want to look at their CWAS score, so on and so forth. So you do all this chart review for every patient. That takes, for me, because I try to be thorough, because I know they're going to ask about it on rounds. For me, it takes like 2 hours. So like from 5 to 7, or like 5:10, 5:20 to 7 a.m. I'm doing chart review. Sometimes to like 7:30. And then, especially if it's a new patient. And then rounds start at 8:15 a.m. So usually when I'm done with chart review at like 7:10, 7:20, whatever, then I need to go see all of my patients before rounds, right? Before everybody else goes and sees the patients together. Which, this is just my own opinion, but pre-rounding is stupid. It makes life easier for the attending, but makes it harder for the resident, because we're already going to see the patient together on rounds. So it's just like an extra, 30 minutes to hour of my time seeing these patients. And usually, sometimes getting good information from them, but usually not. But anyways, so pre-rounding is when I go and see all of the patients myself before rounds, get a good history from them, make sure I do a physical exam on them. And I'll talk about this in a little bit, but the physical exam, usually what I do is I listen to their heart and their lungs, and it's pretty fast, and it's, for most patients, unless they have like heart failure or something, the physical exam, I haven't really been taking it seriously, but I feel like I really should be. I'll get into that a little bit. So anyways, you do that for every patient, and the rough part about pre-rounding is that, like, some patients, and it's not their fault, God bless them, but some patients, they really like to talk, and I get it. It's like an 80-year-old lady, and they like to talk, so and you feel obligated to listen to them and smile and kind of get, talk to them. But, that takes up time, so it's hard making that 8:15 a.m. Time. And then after that, at 8:15, and it's a little bit different for everybody's. For some people, it's 8, so on and so forth. But at 8:15 for my team, we start rounding, and we'll round until like 11:30. And rounding, of course, is like when you as a team go and see every single patient and talk about them. One person will present the patient, then you'll talk about the plan for the patient, then you'll go in and say hello. So that takes a long time. So you're rounding as a team on all of the patients on your list until like 11 or 11:30. At 11:30 a.m., we have morning report, where one resident, the other day was me, but one resident will present a topic. And then, so for example, I presented on AKI, acute kidney injury, but other people will present on other things. And then from 12 to 1, we have noon hours. So somebody will present something and we'll have free lunch, which is great. And then after 1 p.m., it's usually we'll have a new admission. And see, that's rough when that happens because, you know, the plan for every patient is formulated on rounds, right? And so ideally you'd want to get your notes and orders in right after rounds. But if your rounds ends right at 11:30, which it doesn't always end like that. Sometimes it ends at 11 and you have some extra time on the computer before morning report. But if it ends right at 11:30, then you have morning report and noon conference, like a whole hour and a half where you can't work. And so now you're behind on notes, you know, you're behind on orders, and then, oh, there's a new admission, a new patient comes in. So for the new patient, you want to make sure you get a good history from them, do a physical exam on them, do a good med rec on them, you know, what medications have you been taking? Have you been taking these medications? Which, of course, that's always hard when the patient is like 80 years old and takes like 20 medications, because the patient themselves like doesn't really know if they're taking these medications, or if the patient has like altered mental status or whatever. Anyways, you'll do that. And then anyways, 4 o'clock is when the list is run. So until 4 o'clock, you want to make sure you get all your notes and orders done, and then make sure you get all the, you know, business done for the new patients that you see. And then at 4 o'clock, you'll basically do like what's kind of like a table rounds, or we call it run the list, where you'll go over new things for every patient with attending and talk about the new patients. So like, but new developments. So like if you're tracking one thing or another on a patient, you'll want to talk about that with the attending. Or like if a patient complains of a new type of pain, you know, stuff like that, you'll want to make the attending know. Or if the patient has received placements, you'll want the, you know, attending to know, because maybe you can discharge the patient today, maybe you wait until tomorrow. Anyways, that's a typical day. And then after, so running the list takes like an hour. So 5 p.m. you'll get back to the workroom. And then like 5 to 6, you'll want to kind of make sure you make all the changes that you had to make after running the list, or getting in some orders or whatever. And then 6 p.m. is sign out. So at 6 p.m. you'll let the night team know what to watch out for, and hopefully head out by then. Sometimes if I'm lucky, I'll be done by 5:30, because you know, if things are going smoothly. If I'm unlucky, then, you know, I'll be working past 6. So yeah, that's a typical day. But then, you know, when I get home, I want to make sure I'm in bed by like 8:30, because I need to wake up early the next day. So that's a typical day on internal medicine wards. So how have wards been going? Well, like I said in my last video, I make a lot of mistakes on a daily basis. For example, the common presentation format is SOAP. And any medical student knows what I'm talking about, but SOAP stands for Subjective Objective Assessment Plan. So that's how you present patients, right? First you say, this is what happened when I talked to the patient, you know, how the patient feels, blah, blah, blah. This is what happened on physical exam, and these are the lab values, and so on and so forth. Imaging studies, ins and outs, vital signs. And then, you know, this is my assessment and plan. So that's kind of how you present a patient for the most part. But I don't know about other internal medicine residencies, because I don't remember doing this at my medical school. But here, when we're going to discharge a patient, you know, the day before discharge, or like on the day of discharge, the presentation we make on rounds is different. We do something called DDE map. D, disposition. D, diagnoses. E, equipment. M, medications. A, appointments. P, pending. And it's a very logical presentation style for patients who are leaving, because it kind of goes over everything that needs to be written in the discharge summary and needs to be kind of known for, you know, both the primary team in the hospital and the primary team outside the hospital. And so with these types of presentations, I've been struggling because like the first time I did it, I was just like, oh, disposition is this patient's going home, even though the patient was actually going to rehab, but I didn't see that note. Diagnoses, I just, off of the top of my head, without even looking at the note or chart, I just kind of said the reason they're admitted. But I also should have mentioned all the patient's chronic diagnoses, right? So, for example, instead of just saying this patient has, and I'm just like making up an example patient, like for example, instead of just saying like this patient's diagnosis is pulmonary embolism, not resolved, I need to say, okay, diagnoses for this patient are pulmonary embolism, acute kidney injury resolved, obstructive sleep apnea, on CPAP, GERD, hyperthyroidism, hypertension, well controlled, so on and so forth. So I really need to go over the whole, diagnoses list, which I didn't do. And, for equipment, usually that's nothing, but, you might say like, oh, this patient is going to leave on oxygen, which is rare. Usually it's nothing. And then for medication list, again, this is like the most important part of the DTE map presentation. You don't just want to say, oh, we're going to, continue all of his home medications. You really want to go over his home medications one by one and say, we're going to continue this. We're going to discontinue this. Because, the huge part of like discharging a patient is medication reconciliation. Like which medications are we going to start and which medications are we going to change. And you really want to have a good plan for that and review the plan for that with attending physician before you do the discharge medication the discharge med-rec, right, the medication reconciliation. And then appointments, so you want to look at the patient's schedule and see what appointments the patient has and what appointments you want to give the patient. So for example, if a patient is discharging, you want to make sure you set them up with a PCP, a primary care doctor. If the patient came in with a gastrointestinal issue like GI bleeding, you want to make sure that you set up the patient with a gastroenterologist outpatient. And then pending is like, what labs do we have that pending? Like what labs are we still waiting for? And because my hospital is pretty decent sized hospital, like the probably the biggest in the state, but still a pretty small hospital compared to most academic centers. A lot of our labs are pending. They get sent out to places like Mayo Clinic, and so I really need to make sure to state these are labs that aren't back yet, so that primary care doctor, the outpatient doctor, can look at that. But anyways, so like last Monday I did this presentation and I just completely, gave a shitty presentation. I was like, oh, the patient is going home. We're going to continue his home meds. His diagnosis was like this one thing. And then my senior resident, who was really cool, he was nice to me. He was like, okay, because the way presentations work is I present to the senior resident while the attending is standing there, and the rest of the team is standing as well. And then the senior resident gives me feedback, and then the attending gives me feedback and additions to the plan. So the senior resident is looking at me and he says, yeah, okay presentation, but I don't mean to be nitpicky, but like for medication reg, you need to really say every med. And then the attending immediately jumped in and said, I don't think that's nitpicky, I think it's very fair. Because the attending was obviously pissed off that I gave such a shitty presentation, right? So like stuff like that, I'm still working on. But it's just a matter of getting better day by day. And really the worst thing you can do is keep making the same mistake every day, even though I do. But if you are one of those people who does make the same mistake every day, you still shouldn't feel bad, in my opinion, because you just need experience. But anyways, so I've been working on that, but still there are times when I don't do the best job at that presentation, or I just don't have the time on pre-rounds to, like, before rounding, to like look at every single freaking medication the patient is taking at home and deciding whether or not the patient should continue it. or I don't expect the patient to discharge when they really should, and so I don't have their whole medication list on hand. So days, on days like that, I can't give the best DDE map presentation. So anyway, stuff like that. I mean, and you know what? Presentations are something we're always working on. Fine, but I make mistakes on those. Other mistakes I make. Well, I'll just say this. I because I make, at least one or more mistakes every single day. What I started doing is I have a notes app on my phone, and I started to make words notes on my phone. So let me just look at that. In fact, well, I guess I can't look at apps on my phone and film the video at the same time. But anyways, like an example of another mistake is like one patient that I've been following has came in with a different problem that got better, but on the patient's labs they had acute pancytopenia, which means all of their blood cell lines, red blood cells, white blood cells, hematocrits, and then thrombocytes are all decreased, and this was a significant decrease pretty much overnight. Like on the day of admission, the labs were like slightly decreased hemoglobin and hematocrit, but like white blood cells and thrombocytes, meaning platelets, on the lower end of normal. And then the next day, freaking white blood cells are 2, when the normal is like, I don't know the exact normal, but it would be like at least like 8, right? Thrombocytes are down to like 50 when the normal should be like maybe like 200 something. So so I was freaking out on this day, and for a couple of days afterwards, like, what could this be, right? And we did a pretty extensive workup as a team. So for example, I was wondering, could this be disseminated intravascular coagulation, which is an emergency when the platelets clot up, and so effectively you don't have any platelets, and the patient has a chance of bleeding out. But the fibrinogen, which is a lab for that, was normal, so it wasn't that. I was thinking, could this be like a TTP, like a thrombocytopenic purpura, like a like a hemolytic anemia, with the blood cells lysing, things like that. But no, the LDH was normal. Haptoglobin was low, which is expected because the patient has liver problems, so it's not that. And then the indirect bilirubin, which is another lab that you can check for hemolysis, that was also normal. So it's not that. So is it like iron deficiency? No, because the patient's iron came back normal. So I'm just kind of ruminating on this for like 2 days, 3 days, and the attending is also somewhat worried about it, but not that much. I think maybe the attending kind of knew what was going on and just wanted me to figure it out. But anyways, on the yesterday morning on rounds, one of my senior mentioned that maybe this is just where the patient lives, right? In other words, maybe because the patient has a history of liver disease, maybe the patient's blood cells are chronically low, and because the patient was so poorly, had such poor intake on admission, the labs seemed more normal. But now that we resolved that, the labs are back down to like a pancytopenia. And sure enough, I went through the patient's results and kind of scrolled back to like, May of this year, April of this year. And the labs in like May and April look pretty much exactly like they do right now. So, I was just kicking myself. Like, if I had done a proper chart review in the first place, then maybe, we wouldn't be ruminating on why does this patient have pancytopenia for 3 days. So, stuff like that, which I have mixed feelings about. Like, on the one hand, yes, I'm kicking myself for it, because it's like, I'm kicking myself for it because it's not, if I had done the proper chart review, this wouldn't have happened. But on the other hand, and like I said before, I do have an internal locus of control, and regardless, I'm going to do my best to do better chart review from now on. But still, you're so rushed during the day. I'm working the whole day. I barely have any time to rest. That it's just, it's just not realistic to like look at every single thing, But regardless, I still should have looked at that. So, there you go. That it's there's nothing to freak out about. The patient's baseline is pancytopenic. So, anyways, I think the patient can probably leave soon. But then also, before I figured out that this was the patient's baseline, the night before seeing this patient, I was up at like 10 p.m. The night before yesterday, I was up at like 10 p.m. and I was just kind of doing some more research into what could be causing this patient's really low blood cell counts because, I didn't know. I didn't think we had a good answer. And what I came across was splenic sequestration. And how I came across that was this website called Open Evidence, this AI website. And I have a lot of mixed feelings about AI, which I won't get into now. But anyways, Open Evidence is like ChatGPT for doctors. Like you'll put in you'll ask it a question like what are potential causes of pancytopenia, and it'll give you a good answer. Or you can straight up put in like a whole HPI in there, taking out patient identifiers. Of course, it'll give you a good differential diagnosis. So I have a lot of mixed feelings about AI, and I can make a different video about that later. But anyways, the reason this made me kind of kick myself, kind of mad at myself, was because if I had done a proper physical exam, because at this point, like 10 p.m. a couple of days ago, I'm like convinced that it's splenic sequestration, right? And I was like, why didn't you try to actually feel this patient's spleen, right? Because that's something they teach you in freaking medical school, right? When you do an abdominal exam, first you want to do light palpation, then deep palpation, percussion, and then look for hepatosplenomegaly. But, I haven't been doing a full abdominal exam on every patient. For the most part, I've just been kind of doing the light palpation and seeing if it hurts. But, it's just stuff like that where, if I had actually done my job, I would have, been more secure about their potential diagnosis, right? So, again, stuff like that. And then just, like I was saying before, I made a list of like everything I need to improve on. And, other stuff on that list is like, don't forget to look at the core diabetes flow sheet, or, so on and so forth. So a lot of technical things that I can improve on my presentations. So that's the, one of the hard, kind of going through the cons, the bad things first, or the hard things first, and then the good things. The mistakes I keep making, but I've been making an effort day by day to really improve on myself, and I feel like I am improving myself day by day, even if I'm still, making, sound like an idiot every now and then, on rounds and on presentations. And the other thing, of course, is the hours. I won't get too much into it because I just kind of gave you an extensive overview about what it's like, but long story short, it's pretty long. Like, this is my one day off this week. Tomorrow I'll be right back in there, right? And it's already 5:30, so I need to wake up at 4:30 a.m. tomorrow. So I'm gonna take this hike and then go home and maybe do some UWorld questions or something and go to sleep. So there's that. The hours suck because they're so long, and the hours also suck because it's basically, if I want to do a thorough and good job at things, it's basically inevitable that I have sleep deprivation. So my average hours of sleep, because I wear a Fitbit as part of like an intern health study, my average hours of sleep have been like less than 5 hours for the past week. And that really has an effect on you too, okay? Not just on your health, not just metabolically, because of course it does. And I have noticed my pants are getting, more tight, things like that. I've definitely gained weight, um, not just from that perspective, but also from a cognitive perspective. Like my Anki cards, I have some flashcards for USMLE Step 3 that I try to get through every single day. Whereas before the awards block, it was taking me like 20 minutes to get through these cards. Now it's taking me like 40 minutes, sometimes even an hour. Sometimes it's late in the day and I still have a bunch of cards left, and I'll just press, the I'll just press the space bar and get through all the cards without looking at them. Because I'm freaking tired, and because my brain just isn't working as well as it would if I had a proper amount of sleep. And so yeah, like, and the sleep deprivation really gets to you on the wards rotation. Um, so yeah. So like today, and then the rebound happens on the day off. So like I was talking about, slept from freaking 9 p.m. to 2 p.m. today. So I've only been awake for like 3 hours, and I gotta go to, realistically, it's not gonna happen. But if I wanted to sleep 8 hours tonight, then I would have to go to sleep within the next 3 hours. So the hours are terrible. So that's kind of like the bad stuff on awards. But now kind of like looking at the bright side, 3 months into residency on my second block of wards, really my this is like the end of my 6th week of wards, if you only count the wards I've done in residency so far. Things are starting to click. I mean, click and not click. So I'm starting to forget a lot of things from medical school that I knew before. For example, that splenic sequestration thing. I was kicking myself that I didn't remember that. That I should have it should have at least come up in my differential diagnosis, right? But because I did, it was on step 2. So, but anyways, so there's stuff that I'm forgetting because I'm not, doing as much UWorld every day as I used to, or studying as hard as I was during medical school. Mostly because instead of spending those hours studying, I'm in the hospital. But in terms of like the workflow of how things are done in the hospital, how presentations are done, things are starting to click, slowly but surely. I feel like they are. And even though, I don't necessarily know how all of the attendings feel about me, I do get along really well with pretty much all the residents, and they're all pretty good people, and so that kind of stuff is good, and it's rewarding. It's a cliche. It's something that we used to talk about before getting into medical school, right? How rewarding it is to see patients get better and stuff. And now, it's too tiring. We're so tired that we can't really appreciate it. But it is still rewarding to see patients get better. Like a couple months ago, on my previous block of wards, I had a patient come in with severely altered mental status. You could barely answer any questions I asked them. And then it turns out the patient was actually a very nice, good human being. And it was very pleasant to talk to. So just seeing that patient go from being what people on the street would call a crazy person, to seeing the patient, being a nice, grandparent-like figure. That kind of stuff is rewarding, And I do feel like I'm making a difference, but still not with my mind as so much as doing busy work, getting the notes done. Somebody needs to do it, right? So I'm not complaining that much, but getting the notes done, stuff like that, putting orders in, doing the busy work. I mean, I am making a difference. Like I'm definitely earning my my salary, I feel like, but so that is good. I do wish that that I had better thinking diagnostic skills, that I could make a difference in a way that I wanted to, which God willing, inshallah, will come with time. And yeah, the other good thing is just where I ended up in residency, right? Beautiful place. So I'll show you guys 4 dances in a second when I go up that hike. So yeah, that's how Wards is going in residency right now. And then, like, just in terms of my future, I still don't know, man. Like, right now I'm not, right now I'm feeling okay, right? But when I'm in the hospital at like 4 a.m. or not 4 a.m. but like 5 a.m. sometimes 4 a.m. if it's a post call day. But anyways, when I'm in the hospital that early, I'm so angry. I'm just, like, I just can't help but think, like, this is not the ideal career for me, and this is not, I didn't become a doctor so I can freaking not see the sun on a lot of days, except through the windows of patients. So yeah, I don't know, long term, do I want to be a hospitalist? Do I want to be a primary care doctor? Do I want to do a fellowship? Do I want to practice in the United States of America? I don't know, man. It's all, I don't know. So it's something I still need to think about. But the thing about, residency is people apply to fellowships, after their second year, and I need to have, if I want to do a fellowship, I need to have good research, good letters of recommendation, good, stuff like that. So you don't really have a lot of time to think about it. You got to make your decision. That's why I ended up in internal medicine. Now, internal medicine was the right specialty for me, but I also didn't have a lot of time to think about other stuff because I never fell in love with anything, right? I was just, for example, if I had fallen in love with, like, I don't know, ophthalmology, then I would have, tailored my schedule in a way that was ophthalmology specific in medical school, and ended up in that, in that pathway. But I never really knew what I liked in medical school, and so I ended up in internal medicine. And I'm glad I ended up here because this is the right specialty for me. But it's just, my point is, you don't really have a lot of time to think and ruminate on things in medicine or try different things. So I don't know. I'm still thinking about what my future will be like as a physician. So anyways, I hope you enjoyed this update on residency, and now I'm gonna go on my hike and get my exercise in for the day. And yeah, I'll see you at the top of that trail over there. So this is the bottom of the trail, and that's where I am right now, just the parking lot, right? And the place I want to show you guys is right here. It's a 0.2 mile walk. I'm gonna run it, get some exercise in, get a really beautiful view of the city from here. And so yeah, I'll see you guys at the top. Well, I'm at the top. Nice little run up, and it's a nice view, but the better view is right here. Billings, Montana, ladies and gentlemen. So you can see right down here, this is the Rim Rocks. They're the cliffs that surround this awesome city. And you can see that the airport is right there on top of those cliffs. And yeah, sometimes I like to go up on those cliffs after a long day in the hospital. And then the apartment I live at can probably be seen by here, but there's a better viewing area down there. So let's walk down there and I'll show you guys the nicer viewing area. So here you can kind of see the history of this area. And the state of Montana and the American West has been inhabited by different Native Americans, right? Like the Crow Indians were one of them, for essentially thousands and thousands of years before this area was settled. But then this became a railroad town in between the West, you know, California and stuff, and Washington and whatnot, where they found the gold, and the East, you know, the industrial side of the country back in the 1800s. So take a look at this coming into view. It's quite the steep cliff. You can see the city over there. If I was brave, I would go down there. And actually I have gone down there before, but I'm not going to do it without a camera because you have to be careful. I'm not going to go there with the camera in one hand because you have to have both hands, because the rocks are slippery. You don't want to die. But anyways, this city used to be called Colson back in the day. So you see this land right here. Back in the day, that was the city. That's where the old Wild West town was. Colson, Montana. And actually, I think it was Idaho Territory was what this area was called back in the day. And the railroad goes through this area. Let's see if I can see it from my... yeah, there's the railroad. So actually, that was part of it, but really this strip of land right here, this was Colson, the city of Colson, you know, classic Wild West town, and the railroad went right through it. But over time, the city of Billings came up, and Colson kind of died away, so now it's just an empty plot of land over there. And yeah, that's the story of this place. Lewis and Clark, the great American explorers, passed by this place once in a lifetime. So kind of looking at the city on that side, and then if we look at this side here, you can see the Yellowstone River. And back when I was, you can see my video, I was in Yellowstone a few weeks ago, Yellowstone National Park in Wyoming. This river flows all the way to Yellowstone National Park. You know, I don't know where it goes from there. But it's quite the view, and people can go river rafting here and stuff, but it's kind of late in the day. And then there's a trail here that kind of runs down there. Maybe I'll take it, but I think I might go down there. Seems like a nice view. But yeah, this is Four Dances. You know, just a nice little place to hang out when I have some free time. And then there's a story related to this place. This place is called like Sacrifice Cliff or Suicide Cliff or something. Excuse me if I get it wrong, but my understanding is that there was a legend that back in the day, Native Americans used to fall off this cliff and pass away. So, yeah. Just taking this awesome view. But alright, it's a long enough video as is, so I'm going to spend some more time here, but I'll end the video here. I hope you guys enjoyed my residency update or got something out of it. And good luck in whatever you're doing, and yeah, you guys have a good one.